Hello everyone, welcome to Mental Health live webinar on Negligent Credentialing, Strategies to Protect Your Healthcare Entity. My name is Kiara and I'm going to be your host today. On behalf of the Mental Health team, I would like to thank all of you for being part of this event. Today's webinar will be presented by William Copeland. William Copeland, as Managing Member of Copeland Law LLC, Cincinnati, Ohio. Bill Copeland is a seasoned healthcare attorney and executive whose practice concentrates on hospital, physician, and other healthcare-related activities. He is a board certified in healthcare management by the American College of Healthcare Executives. He has extensive experience serving as hearing officer in medical staff dispute cases and as arbitrator or mediator in cases involving healthcare, transactional, or fraud issues. He is in the panels of the American Health Lawyers Alternative Dispute Resolution Service, the National Arbitration Forum. In addition, he has broad experience in healthcare fraud and abuse issues, including the Anti-Kickback Statute, Staff Physician Referral, and the Federal False Claims Act. We are honored to have Bill with us to present the webinar today. Before we begin the webinar, I would like to inform you that the program is outlined for 60 minutes duration. Firstly, Bill will take you to today's webinar, highlighting the areas that will be covered, and then he will share with you his presentation. We would also like to inform you that all the participants, once per the teleconference, have been placed on mute and will remain so until the Q&A begins towards the end of the webinar. It is for the purpose of avoiding discontinuity and for allowing the presenter to speak clearly so that everyone present can take maximum benefit from this webinar. We also request all of you to hold back your questions until the Q&A window begins. 10 minutes of the time will be allotted for the Q&A, during which your questions will be answered. If for any reason you get logged out of this training session or teleconference, please follow the same procedure to join in again. Now that we are all ready to start, I request Bill to take it from here. Bill?
Thank you very much, Kara. And good afternoon or good morning, as the case may be. Today's webinar is on negligent credentialing, and we're going to talk about strategies that will help you protect your healthcare entity. The objectives of this, I want to start by providing a brief history of peer review in hospitals, because I think it's important that we understand exactly how peer review in hospitals developed and how the doctrine of corporate responsibility also developed. We'll also talk about understanding the responsibility of a hospital for monitoring the care provided by physicians in the hospital, and then review negligent credentialing, what it is, how it developed, and talk a little bit about and provide a brief review of state and federal lawsuits involving negligent credentialing. And finally, we'll review strategies that should be taken to preclude liability for negligent credentialing. Let's start with the history of peer review in hospitals. Now, there's no question that hospitals have the ultimate responsibility for the quality of care provided in their facilities. But this hasn't always been the case. Until a few years ago, a hospital was just a workshop for physicians. The relationship between the hospital, its medical staff, and the physicians on that staff has changed rather dramatically over the last 100 years. No question, the hospital has the final responsibility for the quality of care provided by physicians in the hospital. But that does not mean, and let me underscore that does not mean that the hospital is liable for all acts of negligence or malpractice by a physician who practices in the hospital. It means that the hospital must take reasonable steps to make sure that it has selected a competent medical staff, to ensure that the individual physicians on its staff perform only those procedures for which he or she is qualified, and to implement certain quality control measures to verify, underscore verify, that only qualified practitioners remain on the staff and that quality care is provided in the institution. This is a comment from Benjamin Cardozo, who eventually became a Supreme Court justice. But at the time, Justice Cardozo was a judge on the Supreme Court of New York. Let me just read this. I know I don't like to read slides, but this is a quote from Justice Cardozo, and I think it really puts the entire era when we're talking about here, 1914, in perspective. He said it is wrong. They said the wrong was not that of the hospital. It was that of physicians who were not the defendant's servants, the defendant meaning the hospital, but were pursuing an independent calling, a profession sanctioned by a solemn oath and safeguarded by stringent penalties. If in serving their patient they violated her commands, the responsibility is not the hospital's, it is theirs. Interestingly, the hospital's responsibility to its patients at the time was limited to administrative liability. And actually, administrative liability for ministerial acts. There was no duty to supervise the performance of non-employee members of the medical staff, or even to ensure their competence. The theory was that only physicians could practice medicine, and hospital management was therefore inherently incapable of exercising any effective control over the physicians. The physician operated as an independent contractor, and the professional medical process was considered entirely in the hands of the individual treating physician. Professional management of hospitals was almost non-existent. Actually, it was non-existent. It wasn't almost non-existent. And then in 1965, the hospital's world changed dramatically. The Supreme Court of Illinois decided Darlington v. Charleston Memorial Hospital, and the United States Congress enacted Medicare. In Darling, you can say that bad facts make bad law. Well, I don't know whether this is bad law or not, but certainly the facts were bad. It involved an 18-year-old college student who broke his leg playing football. He was taken to the emergency room at Charleston, where he was treated by a doctor on the emergency call. Doctor placed the leg in traction and applied the plaster cast. He then admitted the patient to Charleston Hospital, and the patient remained there for 14 days. During this period, the patient frequently complained of severe pain. There was a stench in the room, and blood and other seepage were observed by nurses and other members of the staff. The hospital did not request a consultation from another physician, even though it was required by state regulations, by the accrediting standards of the Joint Commission on Accreditation of Hospitals, and the hospital's own medical staff bylaws. After 14 days, the patient was transferred to a hospital in St. Louis, where he was placed under the care of an orthopedic surgeon. Interference with the blood circulation caused by the tight cast made amputation of the leg necessary. This was a 46-bed hospital. It was a member of the American Hospital Association. It was accredited by the Joint Commission on Accreditation of Hospitals, now the Joint Commission on Accreditation of Healthcare Organizations, and was licensed by the state of Illinois. No licensed physicians, residents, or interns were employees of the hospital. The physician who applied the cast and was responsible for the course of treatment at Charleston was a 58-year-old general practitioner. He had graduated from medical school 33 years earlier and had not treated a fracture in 3 years. He admitted at the trial that he had done nothing to update his knowledge of fractures since his graduation from medical school. The Supreme Court of Illinois, and I quote, said, "The hospital has failed to have a sufficient number of trained nurses for bedside care of the patients at all times, capable of recognizing the progressive gangrenous condition of the patient's right leg and bringing the same to the attention of the hospital administration and to the medical staff so that adequate consultation could have been secured and such conditions rectified. And the hospital failed to require consultation with or examination by members of the hospital surgical staff skilled in such treatment, or to review the treatment rendered to the patient to require consultations to be called in as needed." The court found that the hospital had a duty, underscore that, a duty to provide adequate nursing staff capable of recognizing the dangerous condition of the patient and informing the intending physician of such condition. And if the physician fails to act, to notify hospital management, quote, so that appropriate action might be taken, end quote. The court said that the hospital's failure to review the attending physician's work or to require consultation was negligence. Pure and simple negligence. The Darling case was something of an anomaly. Not only did it change the relationship between the hospital and the medical staff, but for the first time, the hospital was charged with direct liability for the care provided to the patient under the so-called corporate responsibility doctrine. Now, the thrust of the case is limited. It's limited to the narrow holding that hospital management has a responsibility in consultation with the organized medical staff to establish policies and procedures and to monitor the quality of medical practice. This is to give reasonable assurance that physicians granted clinical privileges to practice in the hospital are competent and they're not likely to commit malpractice or cause injury to the patient. In other words, the hospital owes a duty of care directly to its patients. This is a pretty significant holding in at least two respects. Number one, it bypasses the independent contractor limitation placed upon the hospital's vicarious liability. And more importantly, it recognizes that a hospital's responsibility invades the area of medical care provided by the physician. Now let's underscore that. It recognizes that a hospital's responsibility is responsible for the medical care provided by the physician. Therefore, the hospital must become more directly involved with patient care. I have a quote here by Judge Goldberg in Gonzales v. Newark and Mercy Hospital. I'm going to read it to you because I think it's very pertinent on how this whole area of corporate responsibility has developed. Judge Goldberg said, and I quote, "I have reached the conclusion that the hospital is liable with great reluctance because I am sure that the Sisters of Mercy have done everything within their power to run a proper institution. But they, like every other hospital governing board, are corporately responsible for the conduct of their medical staff." Let's underscore that. They, like every hospital governing board, are corporately responsible for the conduct of their medical staff. He went on to say, "I do not anticipate that they will suffer financially because the ultimate responsibility rests with Dr. North, a person who, by the proper exercise of legal power, intentionally creates liability against the other, is liable to the other for the creation of liability. Mercy is a culprit, but also a victim. As for the doctors on the Mercy staff, two thoughts keep going through my mind. One is from Dr. Jones. No one told anyone anything. The other is from Edmund Burke. The only thing necessary for the triumph of evil is for good men to do nothing." The court in Moore v. Board of Trustees of Carson Tejo Hospital had one of the most succinct discussions at the time of this transcendent role of the hospital and how far it come from its days as a workshop for physicians. The court said, "Today, in response to the demands of the public, the hospital is becoming a community health center. The purpose of the community hospital is to provide patient care of the highest possible quality, To implement this duty of providing competent medical care to patients, it is the responsibility of the institution to create a workable system whereby the medical staff of the hospital continually reviews and evaluates the quality of care being rendered within the institution. The staff must be organized with proper structure to carry out the role designated to it by the governing body. Let's underscore this last sentence. All powers of the medical staff flow from the Board of Trustees, and the staff must be held accountable for its control of quality. Other states followed suit. Washington said the hospital has an independent duty to ensure the patient is not injured through the hospital's failure to supervise medical staff. Georgia says the medical staff acted as the hospital's agents, delegated to screen new physicians, and the hospital was responsible for the negligence in their selection. California. The sisters, like every hospital governing board, are corporately responsible for the conduct of their medical staff. Ohio. It is the board, not the courts, that's charged with the responsibility of providing a staff of competent physicians. Oklahoma. Is an independent duty of the institution itself owed directly to its patients. Ohio took this one step further. Now, I've talked about before, I talked about bad facts making bad law. Again, I don't know whether the tort of negligent credentialing is bad law, but this case was certainly a case of bad facts. In Browning v. Burt, the Ohio Supreme Court drew a distinction between hospital negligence arising out of the care of the patient and negligent credentialing of the physician by the hospital. The court said that the latter was not medical diagnosis, care, or treatment within the meaning of the statute of limitations for medical claims. Now, the big difference here was that the statute of limitations for medical claims was 1 year, whereas the statute of limitations for a tort of negligence was 2 years. They developed a new tort in order to circumvent this 1 year statute of limitations for medical claims. Now let's talk a little bit about the facts. Dr. Burt and Blue were performing love surgery. The court said they negligently, willfully, and wantonly performed unnecessary and experimental vaginal reconstruction surgery without the consent of the patient, restructuring her genital organs to an unnatural and bizarre anatomical configuration. I know a lot about this case because at the time it happened, I was CEO of a sister hospital within the same system. And the thing that, to this day, amazes me is the lack of the hospital CEO and the system CEO to recognize the impact of what was going on. The court said that the hospital has a direct duty to grant and continue such privileges only to competent physicians. And in order to recover for a breach of this duty, a plaintiff injured by the negligence of a staff physician must demonstrate that but for the lack of care in the selection and retention of the physician would not have been granted staff privileges, and the plaintiff would not have been injured. The negligent credentialing causes of action include allegations that the hospital failed to exercise prudence in granting and continuing staff privileges, and failed to conduct reasonable peer review, failed to protect appellees from known incompetent medical care, and otherwise failed to save the appellee from medical treatment of an unnecessary and experimental nature. Now, this hospital is St. Elizabeth Hospital in Dayton, Ohio. Today, that hospital is virtually vacant. It is not a hospital anymore. It was a member of a hospital system called the Franciscan Sisters of the Poor Healthcare System. That system no longer exists. Most of their hospitals either went bankrupt or were transferred to other systems. The hospital that I was a CEO of after I left that hospital, and another sister hospital in Cincinnati, were both given, and I underscore the word given, to the Sisters of Mercy and the Mercy Health System in Cincinnati. That's a member of Mercy Health Partners, which is the parent of the, Catholic Health Partners, which is the parent of Mercy Health Partners in Cincinnati. Other states, I'm sorry, someone have something to say? Oh, that came out. Never mind. Other states have also recognized negligent credentialing. Illinois, and this is an interesting case as well, talking about bad facts make bad law. Under the hospital bylaws and rules, a podiatrist was required to have successfully completed a 12-month podiatric residency training program, passes of at least the written portion of the board certification exam, and documentation of having performed at least 30 procedures. Now, what happened here was there was alleged negligence in performing a bunionectomy on an ulcerated foot that resulted in osteomyelitis and subsequent amputation of the foot. Interestingly, the practitioner didn't meet any of these criteria at the time of the appointment or with subsequent appointments. And the jury awarded the plaintiff almost $8 million. In upholding the lower court's finding of negligence, the appeals court found 3 elements necessary for negligent credentialing. Number 1, the hospital failed to meet the standard of reasonable care in the selection of the physician. Number 2, while practicing pursuant to these negligently granted medical staff privileges, the physician breached the standard of care. And number 3, the negligent granting of the medical staff privileges was the proximate cause of the patient's injuries. Florida says, as a matter of public policy, hospitals are in the best position to protect their patients and have an independent duty to select and retain competent, independent physicians. Minnesota. In this case, the physician had 10 malpractice suits and had been disciplined by the medical board. The Supreme Court of Minnesota recognized the negligent credentialing claim because negligence could be shown on the basis of what was actually known or should have been known at the time of the credentialing decision. Maryland, strong public policy reasons. When there's foreseeability of harm to the patients where the hospitals fail to properly investigate a doctor's qualifications. It also said the hospital is in a superior position to monitor and control physician performance. Kentucky said negligent credentialing is similar to the tort of negligent hiring. Idaho held that peer review immunity statute did not grant immunity for credentialing decisions. Massachusetts, and this is a very recent case, it happened in late 2003, said the credentialing process, the hospital must exercise reasonable care to protect patients from incompetent or careless physicians. Also, compared a negligent credentialing claim to a negligent hiring or retention claim. In Utah, and this one is kind of interesting, the trial court dismissed the case based on the peer review statute. The Supreme Court reversed and said the plain language of the statute does not bar a negligent credentialing claim. The legislature then, in reaction to the Supreme Court's decision, passed, and the governor signed a bill that stated, it is the policy of this state that the question of negligent credentialing as applied to healthcare providers in malpractice suits is not recognized as a cause of action. At least 28 states have found a cause of action for negligent credentialing. 2 state courts have rejected negligent credentialing claims, Delaware and Kansas, and of course, Utah now has a statute on its books that says it's not a recognized tort. Let's talk a little bit about some high-profile cases. And I want to emphasize that the following case studies are presented not examples of cases where the hospital was found to be guilty of negligent credentialing. Rather, they are recent evidence of what happens when a hospital doesn't do what it's supposed to do and is not vigilant. They tend to show what sometimes happens when the peer review monitoring is not effective. This is a case out of Louisiana. The physician was convicted on 51 counts of billing for medically unnecessary procedures and was sentenced to 10 years in prison. This particular guy inserted hundreds of stents per year. The prosecutors brought in expert witnesses and actually showed the jurors angiograms. Expert after expert testified while the angiograms played that where Patil said the the blockages were at 70%. They were in reality as low as 0. They said Patel performed tests and procedures in patients with little or no disease. He falsified patient symptoms and medical records, including chest pain when patients never complained of such pain, and falsified findings on medical tests. 300 patients sued this doctor and the 2 Louisiana hospitals where he worked. There was a class action settlement, which the plaintiffs got $15.1 million. The thing that stands out about this particular case is how could the hospital possibly not know that all this was going on? Were they not reviewing the practices of physicians in the hospital? It certainly seems that way. He admitted more patients than any other doctor. He performed 4 times the number of the next busiest number of stents as the next busiest cardiologist. 4 times as many. Don't you think that ought to stand out? That somebody should have taken a look at this? Of course, they were making lots of money. They made $9.4 million in revenue and $1.4 million in net profit. Twice the amount generated by the next 4 cardiologists combined. It was an assembly line, according to the FBI. And the hospital didn't recognize this? Amazing. Another high-profile case. This one happened in Baltimore. Again, placing unnecessary steps. Found him liable for breaching the standard of care. Documented 90% blockage. In reality, it was 10. They settled a class action lawsuit with 247 former patients. And St. Joseph paid $22 million to the federal government to settle a False Claims Act suit alleging kickbacks. Medee lost his Maryland license in 2011. And the federal criminal probe continues. St. Joseph has now been sold and is under new management. Catholic Health Initiatives, which is the parent, or was the parent of St. Joseph before it was sold, settled a class action lawsuit. Amazing that St. Joseph didn't pick up on this. This is Dr. Patel from St. Joseph London Hospital in Kentucky. He was sentenced to 30 months in a federal facility. He pled guilty. He pled guilty that he falsely reported the severity of patients' illnesses in order to receive payment for numerous heart procedures. 400 people have now sued St. Joseph in London, and 11 cardiologists, including Patel, claiming they conspired to perform unnecessary, risky, and often painful heart procedures to unjustly enrich themselves. St. Joseph Health System in Louisville, the parent, agreed to pay $16.5 million to settle a false claim suit, claiming that it paid doctors in London to refer patients to St. Joseph for unnecessary heart surgery. None of the doctors, incidentally, was a party to the St. Joseph settlement. They're still under criminal and civil investigation, and there are additional allegations of unnecessary bypass surgery. This is a spine surgeon, Dr. Durante, spine surgeon in Mason, Ohio, which is a suburb of Cincinnati. The allegation was that he used scare tactics and lies to convince this one patient that she'd be paralyzed without the procedure. There's more than 170 patients have now filed lawsuits against Dr. Durante. He was suspended from practicing in Kentucky and Ohio, and he faces a federal criminal charges for allegedly billing Medicare billions of dollars for unneeded surgeries that left many patients worse off. He has now fled to Pakistan, and he does not intend to come back. Dr. Colonis. Again, this is one of those cases where he is providing the implantation of pacemakers, and at a 120-bed hospital, which performed more pacemaker surgeries than the largest cardiac care medical group in the state, and more than medical centers 4 times its size. He exclusively implanted pacemakers made by Biotronic, who's also a defendant in the suit. And Biotronic paid him a consulting fee of $290,000 in 2009, and also provided full-time assistance at no cost. The Justice Department is still investigating Biotronic's marketing and sales practices. I can't even say that word. Sorry about that. Obviously, the hospital should have picked up on this. Providing more pacemaker surgeries than medical centers 4 times the size should have tipped somebody off, and they should have picked up on this. All right. Let's talk about strategies to protect against negligent credentialing. Number 1, learn to recognize red flags. On the application, reference responses that are vague and non-committal, where there have been disciplinary actions, where the applicant has resigned from the medical staff, other medical staffs, where there's medical board or professional association investigations, where there's investigations by the Office of the Inspector General or other regulatory bodies such as insurance companies or PROs, where the applicant has had problems with partners or other associates, where there's a problem with the ability to obtain professional liability insurance, where there's a history of liability claims, lawsuits, and or settlements, and where the location of his or her practice, is not in the service area. You need to make a concentrated effort to determine professional competence. To do this, employ an evidence-based evaluation program. Look at practice patterns. Look at patient complaints. Look at morbidity and mortality data. Do case reviews. Do peer evaluations. And look at adverse outcomes. All of these things point to a potential problem. May not be a problem, but also it may. And if you've got these kind of problems existing, then you should do some focused review, perhaps. Look at performance data. Length of stay. Is his or her length of stay longer than the average? Are there adverse events? What about readmissions? Are patients constantly being readmitted? What about the appropriateness of procedures? One of the ways to determine the appropriateness of procedures is to look at the pathology results. Are they taking out normal tissue? What about the use of consultants? What about drug use? Is this inappropriate? And again, autopsy findings and tissue analysis results. These things all point to the appropriateness of procedure. Number one, before you bring a physician onto the medical staff and grant that physician privileges to practice in the hospital, make sure that the hospital can support the practice. Are there adequate staff and resources? Number two, have a good understanding of the immunities provided by the Healthcare Quality Improvement Act and other peer review statutes and regulations. Ohio just passed a law that expanded the peer review statute in the state and the immunities afforded by that statute, and allows for the sharing of peer review information among hospitals. Have an adequate medical staff bylaws and have adequate medical staff bylaws and regulations that delineate the credentials, appointment, and reappointment process and standards. Again, that delineate. Make sure you're specific as to what your credentials, appointment, and reappointment process and standards are. Ensure competent leadership of the credentials, peer review, and medical executive committee, as well as the clinical departments. The worst thing possible that you can do is to have leadership of these committees and these departments that leave good management somewhere down the road. And the governing board should be actively involved in the credentialing process. Now, when I say that, people kind of shiver. But I firmly believe that the governing board should be actively involved in the credentialing process, and that board committees should provide oversight of the credentialing process. The governing board should not be a rubber stamp for the credentialing of medical staff members. Finally, review and implement programs to support the Joint Commission standards relating to focused and ongoing performance monitoring, particularly Standard 3.10, which requires oversight and active monitoring, and medical staff standards 4.10 through 4.45, dealing with evidence-based processes to determine competence and degree of education, training, and experience required to perform the requested privileges and procedures. Active monitoring does not mean once a year. It means ongoing. This process needs to be actively monitored on an ongoing basis. I will stop there and take questions.
Thank you so much, Bill, for that wonderful presentation, and I would like to thank all the participants for cooperating with us. Attendees, if you would like to ask any verbal question, please click on the raise hand option, which is like a palm-like icon, so that I can unmute your phone line to speak to the presenter, or post your question in the Q&A panel, or your questions to chat message. In the meanwhile, please take a moment to share your feedback in the feedback form. This will help us to improve our service and provide you the best webinars in future. Attendees, we still have enough time. Kindly feel free to send your questions to me over the chat. Though I don't see any questions coming up, do you have anything else to conclude the session?
Well, either I completely confused everybody, or I did a good job. I hope the latter is what is important. Again, this is a very, very complicated area of the law. And what you should do is make sure that you're represented by good counsel that practices in this area. I don't think it's going to get any better. I think it's probably going to get worse. I do a lot of fair hearing work as a hearing officer, and I see time and time again that there are problems with the process by which members of the medical staff are appointed and granted privileges. So make sure that that process works. It's an active and ongoing process, and make sure that you have good counsel representation so that it will be an active and ongoing process. Thank you very much for your attention, and I hope that you found the program beneficial. Have a great day.
Thank you so much, Bill. Dear attendees, we are happy to inform you that the webinars will be available in the recorded format and can be purchased from our website, or you can call us at 1-800-385-1627, or you can also send us an email to webinars@mentalhealth.com. We look forward to having you with us sometime soon. On behalf of our presenter and the mental health team, I would like to thank all of you for participating in this webinar and wish you a pleasant day ahead. Thank you so much. Thank you, Bill.
Oh, you're welcome. You're welcome. One final thought of questions after the session is over. Please feel free to contact me through Mentor Health, and I'll be happy to answer any questions that you may have or comment further if that's necessary.
Thank
Again,
you.
have a great day. Bye-bye.